I'm Associate Professor Catherine O'Connor. I'm a sexual health physician based in New South Wales and working in Australia and the Pacific. Today, I'm going to talk to you about monitoring and care of the HIV patient on therapy. So these are my disclosures. So the aim of this presentation is to, first of all, document the response to therapy and recognise suboptimal treatment response. Secondly, to recognise which tests are required, their interpretation and their frequency. Thirdly, when to refer a patient with abnormalities in blood tests or clinical parameters. And fourthly, to recognise HIV-related drug toxicities and to be monitoring patients at different stages of their therapy. Okay, so if we're monitoring patients, we need to be not only thinking about HIV control, we need to be thinking about drug toxicities, sexual and reproductive health, screening for renal, liver, bone, mental health issues, as well as cardiovascular health. We need to be looking for co-infections and to be doing cancer screening. There are 5 scenarios of HIV patient monitoring. First of all, in someone who is ART naive, someone who's recently started ART, someone who's stable on ART, those that have had a recent change in ART, and those that have been stopped ART by the patient. So how often do we need to do a clinical examination? Certainly we need to do one at baseline. If the patient has new symptoms, if there are new side effects reported, and we should do an annual examination to look for signs of metabolic changes. So let's look at documenting the response to therapy. What are your key HIV surrogate markers? The most useful surrogate markers before ART is the CD4 count. And we need to consider both the number and the percentages of CD4 cells. It needs to be accompanied by a full blood count or a lymphocyte count. We know that the normal range for CD4 is 1200 to 500, but there is significant variability. So if we're thinking about the clinical utility of a CD4 count, we need to be, first of all, it gives us a current risk of opportunistic disease, indications of which prophylaxis or we need to have the patient on, and when it's appropriate to stop prophylaxis, and the risk of progression to HIV disease. We also need to look at CD4 counts when people are on ART. So we would look at the CD4 rise, but we need to understand that this can be slow and incomplete. If you've had a very, very low CD4 to when you were diagnosed, so it was 20, you may never get back to 500. And there's even in your CD4 rise, it will be slow and behind the virological response. We need to look at the trends of the response rather than one unexpected reading. And we need to counsel our patients about CD4 gains, because often you'll get great joy when there's an an increase in CD4, a very significant increase in CD4. And the next time you do it, when it plateaus, there'll be great distress. So you need to be educating your patients about what to expect with their CD4s. It's not going to be an even increase. We need to be repeating testing every 3 to 6 months. So when we're looking at monitoring our HIV patient on ART, the CD4 count does, however, give us significant information. It gives us a guide as to when to stop prophylaxis for opportunistic infections such as PJP. We need to repeat yearly after the CD4 count has reached 200 for 2 years, and the patients are clinically stable and virologically suppressed. And once our patient has reached 500 cells and is fully virologically suppressed, then CD4 testing should be optional. Often the CD4 count is the focus of the patient consultation. As I said, it can be a cause of great stress. So education is required. And it can be quite variable. We look at a 30% change in the absolute count or a 3% change in our percentage of CD4s. So let's just look at an example. So Hamish is a 30-year-old man who's ART naive, and firstly his initial CD4 in May is 670 with 32%, and then in October the CD4 falls, inverted comma, to 500 with 30%. So when Hamish comes in, he's probably going to be a little bit concerned about this. Let's look at another reading that's possible for Hamish. He starts with his 670 and his 32%. When he comes in January, it's 450 and 26%. Would we be equally concerned about both changes in reading? So as I said, it can be quite variable, 30% absolute change or 3% percentage. So educate about CD4's absolute count jumping up and down, and reassure patients that a single change doesn't really mean much. So as we can see, the first change from 670 and 32% to 530% is not significant. So we need to reassure patients in this situation. However, the second change is clinically significant, and we need to investigate further. Now, let's turn to the HIV viral load. This is the most useful investigation after ART initiation. And it's our key parameter to judging ART efficacy. So it's measured as a count of plasma, so copies per mil of plasma, and as a log. So 100,000 copies is log 5 or 5 log, and a 1 log drop is 10,000, i.e. 10,000. We consider a significant change as a 3-fold change. So that would be a 0.5 of a log. So a change from a viral load of 20,000 to 10,000 is just within the test variability. It's not significant. As I said, viral load is the most important test after ART initiation. and we expect a significant response after ART initiation. At 1 month, we would expect a 1 log or a 10-fold drop. And by 6 months, we would certainly expect the viral load to be below the level of detection. So what happens if these changes don't happen? What does this mean? Well, we need to, first of all, assess the patient's adherence to therapy. Patients will often say to us that they're taking their medication 100% as a way of pleasing the doctor and keeping everything happy in the medical relationship. However, we need to make sure that the patient is actually adherent. Are they forgetting? Is there side effects that they're having, and so they're not taking their medication as they should? We need to check for possible drug interactions which can be causing problems with the effective dose of our medication. And in a future presentation, we're going to talk in detail about drug interactions with HIV drugs. And we need to check the dose we've prescribed, look at compliance with food restriction, as we know that some of our drugs that we give have significant food restrictions. If we can't find any reason why our patient should not have responded to medication, then we need to be ordering a HIV resistance test to ensure there's not HIV resistance. So let's talk about some definitions. Virologic suppression is HIV RNA below the lower level of detection of the assay, so that's less than 20 copies per mil or undetectable. Virological failure is the inability to achieve or maintain suppression of viral replication below 200 copies per mil. Virological rebound is when we've got to less than 200 copies per mil, and then we bounce back up to greater than 200 copies per mil. So some important practice points are that if we fail to achieve a 1 log drop of viral load at 1 month post initiation, we need to look, because this is often a harbinger of virological failure. And obviously, if we've got more than 200 copies per mil, this is virological failure, and we need to act urgently on this. So why is virological failure so important? Well, if unchecked, it can lead to virological rebound to the pre-treatment levels, and you get immunological failure. People can go on to clinical progression and severe opportunistic infections. But also, they're in this situation, if people are taking medication and they're failing, then they will be generating viral mutations conferring resistance to classes of drugs. And the issue with this is that within the HIV medicine context, once you've got a resistance, you're stuck with it forever. So it can cause lots of problems in the future, trying to look for treatment options. So there are other scenarios apart from virological failure that we need to be aware of. First of all, you can have a viral load blip, and this can be a transient elevation above undetectable in previously a well-controlled patient. And this blip is usually less than 200 copies. By definition, it's not sustained, so you see it in one test, and then the next test you go back to undetectable. We don't really understand the actual significance, but it always requires repeating if people have had a low-grade viremia. And it obviously can generate a lot of anxiety in our patients. It is important to talk to patients about adherence and drug interactions in these situations. And there is some evidence that it can be due to intercurrent infections and possibly STIs. Okay, so there are some other scenarios that cause a picture that we need to be able to clearly see as different from virological failure. So some people will have a persistent low-level viremia, and that means a viral load between 50 and 200. In these situations, we need to check for adherence, food and drug interactions. And we need to be mindful, however, that the likelihood of patients developing resistance in this situation is low, but we need to monitor them quite carefully. So here we've got two different patterns. So the dotted pattern, where the viral load goes up to 100,000, that's not a blip. We can see in the other pattern, these are very low-level viremias of around 200, which are just little dots, and the patient then goes back to below undetectable levels. So these are very different patterns. So what other tests do we require when we're monitoring our patients? So if we're monitoring a stable patient, we need to annually do a physical examination. Cardiovascular issues are very important in people with HIV, as well as looking at 3 to 6 monthly their CD4 and viral load. We need to do a full blood count at the same time, liver function tests, look at their renal function regularly, which is very important in the context of HIV, as some of the drugs that that patients take can be quite nephrotoxic. We need to be doing their Framingham risk calculator annually, looking at their metabolic issues with fasting lipids and glucose every 6 months, or if they're abnormal, annually if they're normal. We need to be looking very carefully at their other issues, so smoking, alcohol, substance use, and in an opportunistic way trying to have a harm reductive approach. Also monitoring them for mental health issues and intimate partner violence is very important. We need to be looking at doing some cancer screening. So in women's cervical cancer testing, there's some controversy around anal cancer screening with annual digital examination in men over 50. We also need to be not forgetting the cancers that are not increased in people with HIV, but are important issues as all our patients grow older. So bowel, breast, and prostate. And also looking at our patients with for hepatocellular carcinoma who've already got chronic hepatitis B and C as well as HIV infection. We need to also be screening our patients regularly for viral hepatitis, in our non-immune patients for hepatitis B and everyone for hepatitis C. Now, there are some other tests that we need to be doing in our stable patients. For sexual health testing is really important, and you'll find testing guidelines in both the STIPU guidelines website and the STI and the Australian STI guidelines. There are guidelines for MSM, about regular syphilis, chlamydia, gonorrhea testing, and in non-MSM as well. Okay, ASHM has an excellent HIV monitoring tool, which looks at ongoing patient review from an initial assessment to follow-up. And that's the link to the monitoring tool. I'd suggest you all look at it. So there are other issues to consider. We need to be looking carefully at ensuring that our patients' vaccinations are all up to date. Influenza vaccine, pneumococcal vaccine, there's HPV Gardasil 9 is now available. Our patients need to be fully hepatitis B vaccinated. And for men having sex with men, there are 2 extra vaccinations, hepatitis A and meningococcal vaccination that are suggested. So there's a website which you're all probably aware of, which has the Australian Vaccination Handbook. And you may not be aware, but the pneumococcal vaccination program has just suggested a new schedule for pneumococcal vaccination, and our HIV clients would fit into the children greater than 12 months, adolescents, and adults with of any age with the diagnosed with a risk condition. HIV is a risk condition. So please go back and have a little look at those. And here we have our updated vaccination provider. Okay, now there are some special investigations and monitoring that we need to do if we have patients on some drugs. So tenofovir digoxin fumarate, or TDF, can be associated with acute and chronic renal failure. It's much less likely on tenofovir alafenamide or TAF, but we should always check EGFR and urinalysis for protein and glucose as a baseline pre-initiation for our patients on TDF. And we should monitor our patients with for proteinuria and their EGFR closely. Now, tenofovir is not commonly used. Tenofovir digoxin fumarate, or TDF, is not commonly used in Australia today. However, there are some situations, such as pregnant women, where it is suggested to use it. So need to be quite mindful of this. We also need to ask patients at every visit what drugs they're taking. So prescribed drugs, over-the-counter medication, herbal medication, and recreational drug use. We need to be mindful that proton pump inhibitors can interact with atazanavir and cause virological failure. In people that have asthma or hay fever, the use of fluticasone when they're taking ritonavir or Convostat can cause a Cushingoid syndrome. So most important to warn patients about this so they can be mindful. So we need to be, as HIV clinicians, be very aware and alert regarding HIV drug interactions. Now, there's a HIV drug interaction checker that you need to have a look at. It's the Liverpool University HIV drug interaction checker. All HIV clinicians use this drug interaction checker. It's fantastic. So it assists us when every time we see our patients, check for medications, or if you're changing drugs, check their medications, and check them on the Liverpool HIV drug checker, because it has the most up-to-date information, and it's put in a very useful way. We also have a responsibility to educate our patients about the importance of drug interactions, so they're mindful when they're going to the chemist. Okay, so let's now look at 3 common clinical scenarios. So first of all, we have virological failure. Second, someone who's stopped therapy. And thirdly, someone with a treatment change. So now we're going to talk about some scenarios of virological failure. The first one is Peter. Peter is a 65-year-old MSM, and HIV was diagnosed in June 2012, and his Nadir CD4, which is the lowest level of his CD4, was 206 cells per microliter. He's had no AIDS-defining illnesses. There was no resistance on his baseline genotype. He was commenced on TDF-FTC, which is called Truvada, and raltegravir in July 2012. And then he was switched from TDF-FTC to TAF-FTC, which is called Descovy, in February 2017. This would have been just after TAF actually came onto, or Descovy came onto the market, because obviously TAF has less renal effects, which is important in a 65-year-old man. So he attends for a routine monitoring visit, and he tells you that he's run out of Descovy, but he's still got a bottle of raltegravir. And of course, being a very sensible GP, your alarm bells ring, and you do an assessment of his adherence, as you do at every visit. And it turns out that probably he's missing 2 or 3 doses of raltegravir a week. And this is because sometimes he forgets, sometimes he falls asleep before he takes it. And when you do his viral load, it's 1,682 copies per microliter, whereas previously it had been undetectable. So we need to develop a plan. What's your plan? So we decided that we would request an urgent genotype. Need to make sure that when you do a request, you include the current and past treatments. And if you want to do an integrase resistance test, so if they're already on integrase, you would make sure you specifically ask for it, because it's not standard of care. You next of all need to explore and support adherence with while you're awaiting the resistance test. So you need to think about looking at things like mobile phone reminders, dose set box. And you need to also consider whether you can have a drug regimen that you can use once a day, because that is likely to have less problems with adherence than a twice-a-day regime. We wouldn't, however, go on and add an extra drug into the regime while waiting, as this may compromise the drug and cause resistance to the drug while we're waiting for our resistance profile. We need to ensure that we assess a full ART history and access full ART history and any previous genotype testing. We need to modify treatment once we've got the resistance testing. And as I said, consider, if we can, a daily dosing medication rather than BD. Daily dosing is much easier for people to comply with. We need to review the patient in 2 to 4 weeks after the switch to discuss adherence, treatment toxicities, and to repeat our bloods, including viral load. So now let's look at another scenario, and this is the scenario of when someone stops therapy. So Carlos is a 31-year-old MSM. He was diagnosed in 2016, and his CD4 nadir is 717 cells, or 38%. He's never had an AIDS-defining illness. He's got no resistance on baseline genotyping, and is HLA B5701 negative. Because he was HLA B5701 negative, he was able to be commenced on abacavir. So he was commenced on Triumeq, which is a combination of abacavir, 3TC, and dolutegravir in October 2016, and has had an undetectable viral load in December 2019. He attends for a routine visit for monitoring. He tells you that he developed a truncal macular rash while travelling in Southeast Asia 9 weeks ago. He was worried about abacavir toxicity because you'd previously talked to him about it, and so he ceased the Triumeq 3 days later. When you see him, his viral load is 2,123. You do a syphilis serology, which has an RPR of 1 in 64, and it was previously non-reactive 4 months ago. So you know that this is a new syphilis infection, and it does fit the clinical picture of secondary syphilis. So what would you do? So obviously you're going to treat his secondary syphilis, but you would also consider other causes of the rash. So in the absence of an obvious cause of the rash, such as his secondary syphilis, you would always consider abacavir hypersensitivity, as we know this is a very serious condition, and a negative HLA B5701 result does not completely exclude it. So we need to be talking, if you're a new prescriber, talking to a senior clinician mentor to get some advice in this context about recommencing abacavir. However, because it's highly likely that this patient has sick, it's unlikely that he has any resistance, because he stopped the regime simultaneously, and they've all got similar half-lives. So we'd be happy that he almost certainly didn't develop any resistance from stopping his Tramic. We would review him in 2 to 4 weeks to discuss adherence, to look at treatment toxicities, and to repeat his bloods, including his viral load. As I said, a genotype is unlikely to be helpful in this situation, and as there's a very low risk of developing resistance, because of the reasons that I had explained. So now let's look at treatment change. So Paula is a 42-year-old heterosexual female. Her HIV was diagnosed in January 2017 during seroconversion after overseas travel. She had an Nadir CD4 of 421 cells per microliter, which was 23%. She's had no AIDS-defining illnesses, no HIV resistance on her baseline genotype. So it was opted to, she started on TAF, FTC, EVG, and Combistat. So TAF, FTC, Elvitegravir, and Combistat, which is known as Genvoya, in February 2017, and she had an undetectable viral load in May 2017. She attends with worsening psoriasis and a probable new diagnosis of asthma, and her local GP has given her an inhaler with inhaled steroids containing fluticasone. And you've talked to her already about drug-drug interactions, and she's concerned about the possible interaction between Combistat and corticosteroids. You've done her bloods, and she's got an undetectable viral load, and her CD4 count is 907 cells per microliter, or 41%. So what's your plan? And the other thing that I would comment on is whether Genvoya in this situation is an appropriate first drug to put somebody on. There are good things about Genvoya, such as that it has one of its constituents is TAF, so it doesn't have the renal toxicities and bone toxicities of TDF. However, it contains Combistat, and we know that both Combistat and ritonavir have really high levels of interactions between many other drugs, and recreational drugs included, and over-the-counter medications. It also includes Elvitegravir, which doesn't have as high a barrier to resistance as some other integrase inhibitors, such as dolutegravir and bictegravir. So I would be wondering whether Genvoya was the appropriate choice. So let's get back to our patient. First of all, we need to look at her for symptoms of Cushing's syndrome, because we know that she's at risk of it. And secondly, we need, as she's using a contraindicated corticosteroid, we need to look at seeking advice as to whether we may be wanting to do a morning cortisol in the absence of clinical symptoms. Need to discuss her asthma management, using treatments that have got a low potential for direct drug interactions, and think about whether it's better to do this or to switch her ART. I can report that her morning cortisol was normal, and we switched to Descovy dolutegravir, or TAF FTC dolutegravir. With permission, we would also write to her GP and talk about drug interactions and the Liverpool drug interaction website. At 4 weeks, 2 to 4 weeks, we need to talk to her again about and review her regarding adherence, treatment toxicity, repeated bloods, including a viral load, and look at her comorbidities and management thereof. So Paula didn't have any baseline resistance and never had virological failure. So there are some other options for Paula. And the two other options, as I see them, are Biktarvy, which is equivalent to a regime of Descovy and dolutegravir, and that has the advantage that it's one drug, and it's consequently usually cheaper for the patients. However, in New South Wales, this isn't such an issue. And the other is Juluca, which is a combination of dolutegravir and rilpivirine. Now, we can use fixed dose dual strategies in some situations. We can use it as a switch when somebody is virologically suppressed, but we will never use it as first line in initial treatment. It's 1 pill daily. It's a switch, not initial treatment, and it is NRTI sparing. So we're not using any drugs such as tenofovir and abacavir, and this is important when these drugs are contraindicated. We need to be very careful to make sure that the conditions of their use, of its use, are met. So, as I said, there needs to be virological suppression at the time of switch. There needs to be no known or suspected resistances to either NNRTIs or integrase inhibitors. This is probably a good option for Paula because she doesn't have any resistance or history of failure. It removes the booster with the issues of direct drug interaction from her with her asthma treatment. But there is the issue that because there's rilpivirine, there's a food requirement, and proton pump inhibitors are contraindicated. So we need to look carefully at what is the best option for Paula in her individual situation. So now let's just look at some case studies. Okay, so let's just look at some case examples of monitoring after treatment initiation. So Daniel is a 30-year-old gay man who seroconverted to HIV 3 years ago. He was unwell for several weeks at the time of his seroconversion, and his CD4 was at that time 450 cells per microliter. Since then, it's made a progressive decline to a CD4 of 250. He made a very poor adjustment to his HIV diagnosis and resisted starting therapy. However, now his CD4 count has frightened him. And he has recently started on Genvoya. So we've already talked a little bit about Genvoya and the choice of this for as our first line therapy. Firstly, I suggested that the good thing about it was a once-a-day medication and it had a TAF component. However, it did have combistat in it. Combistat and ritonavir both have lots and lots of interactions to both prescribed medications, over-the-counter medications, and recreational drugs. So ideal to avoid combistat and ritonavir if you can in initial regimens. It's also got elvitegravir, which has significantly less barrier to resistance than both dolutegravir and bictegravir. However, he has started on Genvoya and he comes back at 2 weeks for a visit as requested. So at the 2-week visit, you're really interested in looking at safety and adherence. So you check his adherence, make sure he's set up some reminders or alarms. Basically, the first month or so after people start drugs is the really important time for them to develop a pattern of taking medication. So really important that you're checking on adherence at that stage. Check that he's taken the appropriate dose and he's also timing it appropriately so that he understands he needs to take it at the same time every day. You need to check for symptoms of toxicity and side effects from the medication. And you also need to perform laboratory testing. So you look at a basic urea and electrolytes, liver function tests, full blood examination, count examination. You wouldn't do a viral load or a CD4 at that stage because it's too early and you need to tell your patients it's too early. You're not going to get a clear picture. So at 4 weeks, you get him back to do a CD4 and viral load. This is the time to check for efficacy. Really important in this early stage after treatment initiation that we treat toxicities proactively, as unrecognised side effects are commonly a cause of poor adherence. And so we need to be very much aware of any side effects that people are having in that early situation. Now, let's look at a different case. And this is a case of Jasmine, who is a 34-year-old female. And she's previously taken AZT3TC and Kaletra, which is lopinavir ritonavir, but has not attended for 6 years. From the records, you note that her CD4 count was 280 cells per microliter and viral load 100,000 copies prior to starting therapy. And her last bloods 6 years ago was 680 cells per microliter and viral load was undetectable. Jasmine tells you that she stopped her therapy shortly after her last visit 6 years ago. She now has a new partner, and we're wanting to think about which blood tests we'd order. So, firstly, it's really important that you establish have a discussion with her and establish a good relationship. This patient was lost to follow-up for 6 months, for 6 years, so there's obviously major issues going on for Jasmine. So probably I'd be quite gentle, but certainly we'd want to be examining her. And we'd be wanting to do some blood tests. essentially we'd want to repeat all the baseline investigations because there's been such a long gap. We'd want to look at specific sexual and reproductive health issues such as safe sex, condoms, contraception, pregnancy, STI screening. We want to talk to Jasmine about the legal requirements to disclose. She needs to be using condoms with her partner, and she needs to disclose to that partner that she has HIV, and that the person needs to have PEP available. The partner needs to have PEP available if he's had sex with Jasmine in the last 72 hours. In follow-up visits, we obviously need to also think about cervical screening. So you're not going to be able to do everything in the same visit, but we need to be working through these issues. Need to carefully reevaluate patients who've had a significant treatment of interruption and have not attended for a long time. Really important, I think, that you have alerts on your medical record system so you can follow up patients who don't attend and remind them to attend. So we know that Jasmine was immunosuppressed prior to initiating therapy, and her CD4 count almost certainly would have dropped to pre-therapy levels rapidly, and she's probably got an increased incidence of AIDS and non-AIDS events when she stopped after stopping therapy. So, it's 6 years, and her nadir was just over 200. So she is certainly going to have a low CD4 count. I would be expecting probably about 100. We need to be all below even. We need to be having a goal of restarting ART safely and as soon as possible. We need to be doing a history and examination looking for signs of immune suppression and opportunistic infections. Need to be doing a viral load and CD4 count. As far as the genotype goes, she's been off ART for 6 years, and almost certainly her genotype, even if she had some resistance, would have gone back to wild type. So you're not going to see the resistance. We'd certainly be doing routine biochemistry and hematology, checking up on her vaccinations, co-infections, and looking at a chest x-ray. If she was unwell, and this is the reason she's presenting, or if we suspected an opportunistic infection, we would be referring her to a hospital. So this is going to take a little bit of time, and you're going to be needing to see Jasmine probably a couple of times in the same week, and then several times over the next few weeks to get things back on track. And probably this is also going to be a good time to reestablish your relationship with Jasmine. Okay. So why do patients interrupt therapy? Sometimes it's drug side effects that we're not aware of or that they're just sick of. Sometimes it's lifestyle factors, including occupational and travel. And this can be FIFO workers, people having to work at night, people who've had their timetables interrupted. People are travelling overseas and they're worried that they'll have to show their drugs at customs, or they're having to travel and they're worried that there'll be they might be in someone's house and their drugs will be seen. They can be frightened of stigma and disclosure, people coming to their house and seeing their drugs, them staying somewhere else and their drugs being seen. It can be a new episode of depression. So, or drug use or alcohol use, so that they start missing drugs and then they eventually just stop them, can't be bothered going back to get more. It can also be due to lack of knowledge or the benefits of antiretroviral therapy, and sometimes are false or real or perceived side effects of the ART therapy themselves. So now, why do we recommend lifetime continuous ARV therapy? It's a very, it's a very big commitment from our patients, but we need to understand, and they need to understand also, that there is a twofold increase in mortality in those that cease ART, that there's an increase in progression to AIDS and an increase in progression to non-AIDS events. When we're thinking about the risk of resistance, if people stop medication, that is, they take it one day and they stop and they're not taking it the next, then there's probably not that big a risk of resistance. But most people who cease ARV medication of their own volition will sometimes have a period of poor adherence before this, and this is when the real risk of resistance comes to the fore. So let's now think about another clinical scenario. Brian is an elderly gay man who's been HIV positive for 15 years and who's been taking Descovy, which is TAF and FTC, and atazanavir and Combistat for 2 years. And previously he had been on TDF, FTC, and atazanavir ritonavir. So he was swapped because of the renal issues. His CD4 is 400 cells per microliter and his viral load is undetectable. He's got chronic kidney disease with a stable eGFR of 40. He is now switching to Biktarvy, which is TAF, emtricitabine, and because he's keen to take a 1 pill a day regimen. What do you think of this option? What further information do you require, and what monitoring is required after switching therapy? So if we're going to talk about switching to a single drug, we need to only be considering switching a single drug for toxicity, convenience, or expense in some situations where people are paying for 2 drugs and they only want to pay for one. We only need to be considering switching when the viral load is suppressed. So you always ask yourself, will the new drugs and regime maintain virological suppression? So need to consider the potency of the medications and the patient's resistance profile. We need to review his previous antiretroviral history and review past genotypes. Will there be any new toxicities with his new regime? So with this patient, you'd be very mindful to look very closely at renal toxicities because of his chronic renal failure. And will there be no any new drug interactions that there weren't when he was on the old medication? So it's important for new prescribers to discuss these issues with their mentors. In practice, we need to ensure that there's no loss of virological control post-switch, so monitoring their viral load carefully. We need to be vigilant for new toxicities. We need to be practical. So from my point of view, it is practical to have someone on one medication rather than two, even if they're equally efficacious. We need to repeat their urea and electrolytes, liver function tests, and full blood count at 2 weeks, looking specifically for early renal toxicity or hepatotoxicity. And we need to do their viral load and CD4 count at 1 month post-switch, as well as fasting lipids, glucose, and urinalysis. There's no specific need to examine these patients. And if everything's okay, we could probably go back to the pattern that we had of annual screening and disease prevention. So I just wanted to mention to you all that there's really lots and lots of really useful resources on ASHM's website. So do go and have a look, because this stuff that I use with my patients very regularly, and certainly I think that you'll find it all very useful as well. Now, are there any questions?